Hello everyone, this is I will teach you medicine. We are discussing about the diseases of the external air. We have already discussed some topics in the part 1 and we will continuing on this part 2. So without any further ado, let's start with the topic diffuse otitis externa. Diffuse otitis externa, or DOE as I like to call it, is also known as Singaporean air or Hong Kong air. So what is the etiology? So what are the etiological factors that can lead to DOE, that is diffuse otitis externa? That is hot and humid climate, so excessive sweating in the heat, in the hot temperature changes the acidic pH of the air canal into the alkaline pH. Especially in Nepal we can see that in the Tarai region, right? So that's the number one etiology. Second is the trauma. So in any kind of either due to that is investigative or therapeutic instrumentation, it can lead to the trauma, so that can also lead to the diffuse otitis externa. And excessive swimming, that is DOE is also known as swimmer's ear. Swimmers here, you can see this on swimmers, because of the acid pH change in the pH, and also it is due to it is also can be seen in the swimmers, so it is also known as swimmers ear. So these three are the etiology of the diffuse otitis externa. So in the clinical picture, you can see two kinds of phases, okay? Acute phase and chronic phase. In the acute phase there will be otalgia, means lots of ear pain and ear itching. So we have to keep this in mind. So if for otalgia we can give anti-analgesic, and for in ear itching we can give antihistamine, and then for the serous or purulent ear discharge we can give antibiotic and all. And there is a collection of debris in the external auditory canal, okay? So that will lead to conduction deafness and cellulitis, infection of the skin. So for this we can treat with the meticulous ear toileting. We will read about this in the treatment part. And in the chronic phase, we can see the scanty discharge with crusting, because of the crusting occurs because the discharge, purulent ear discharge, it has it crusted, due to the temperature and all. And then we can also see the meatus, the meatal skin that thickens with the fissuring, and then stenosis of the external auditory canal occurs, so. And it rarely occurs, but also stenosis can be occurred in the diffuse otitis externa. So here we can see this is the acute phase, all right? So here is all reddish discoloration, like this person has ear discharge, and then pain, and then itching and all other symptoms. And here is stenosis can be seen in the chronic phase. So on the treatment, we already discussed, it is by meticulous ear toilet, by dry mopping or suction, by using a suction or dry mopping. And then we can use medicated ear wick of antibiotic. Okay, so what is a ear wick? So it's like a gauze piece, all right? So here it is gauze, like cloth, uh, what to say, like a thing in which you will insert it into the ear canal, right? So ear wick is inserted here, and then you can put some antibiotic or any kind of drops, then it will go by itself, so, and will keep the area medicated. So that is ear wick, okay, of antibiotic and steroid cream. So for diffuse otitis externa, we can do ear wick insertion with antibiotic and steroid cream, or we can use 10 percentage of icthamol or glycerin, 10 percentage of icthamol. So this is antiseptic, and glycerin is hygroscopic nature. So this will also cause less infection. And we have to put this air wick for 2 days, and after that we can substitute with the antibiotic ear drops, for the patient compliance. So we clean the air, we have put down the antibiotics required. So now this is local, right? Now we have to go for systemic. So systemic antibiotic is also given for analgesic, ear itch, otalgia. For otalgia we prescribe some NSAID drugs, according to the patient compliance. And then antihistamine for itching, okay? We can also see the itching. So but also in cases for example stenosis, it is rarely seen, but in refractory stenosis of external auditory canal, we can always do surgically excision of the thickened skin, whatever the skin that has been thickened. And then we can bony meatus can be wind, and then split skin grafting can be done. So this process is known as canalplasty. So here we can see here canalplasty is done. So now let's discuss about the malignant otitis externa, or as I like to call it, MOE. So we have discussed about DOE, diffuse otitis externa. Now replace D with E, yum. So that is malignant otitis externa. So malignant otitis externa is very dangerous, right? So its name has malignant, okay. Also its name has necrotizing. Its another name is necrotizing malignant otitis externa otitis, okay. So what is the definition of MOE? That is aggressive and potentially life threatening infection of soft tissues of the external ear, okay. So it is like very aggressive and dangerous condition of the ear, like it can even threat your life, right? So how? Because it infects the soft tissue of the external ear and the surrounding structures, quickly spreading to, because spreading because of malignancy, all right, not malignancy because it is malignant. It spreads to involve periosteum and the bones of the skull base, right? So its name is self-explanatory. Necrotizing means it can like cause like like dangerous effects, and malignant means it can travel. External otitis externa means outer ear. So aggressive and potentially life-threatening infection of the soft tissue of the external ear and surrounding structures, quickly spreading to involve the periosteum and bones of the skull base. So what are the culprits for this malignant otitis externa? So it can be caused by the pseudomonas aeruginosa or staphylococcus or aspergillus, right? So what are the patients that are more targeted by it? That is predisposing factor, that is immunocompromised patient. So anyone with the diabetes, or who are on steroid, or are using chemotherapy for cancer and all, and then AIDS. So they have predisposing factors, they are the predisposing factor. So how does it presents clinically? Okay, clinical profile. Nocturnal otalgia can be seen. This is a very important MCQ question with MOE, okay, malignant otitis externa. And then we can see blood stained purulent ear discharge, resistant to topical antibiotics. So suppose if you went outside your pharmaceutical, your local pharmacy, for like purulent discharge, and he thought it is any kind of like normal discharge, infection. So he prescribed, he gave you, not prescribe, he cannot do that legally, but he gave you an antibiotic, topical antibiotic, and you have been keeping it in your ear for more than 10 days, okay. Still there is still like red color discharge and purulent discharge, blood stained discharge, okay. So there is nothing no any signs of healing has occurred in your ear, all right. So that can be also a clinical profile of malignant otitis media externa. And then we can see the granulation tissue at the junction of the cartilaginous and the bony external auditory canal. So EAC we know, okay, this is like this, okay, this is the outer ear and all, inner ear and all, you already know. So in the external auditory canal you can see 24 millimeter, right? Its length is 24 millimeter, out of which 8 millimeter and 16 millimeter it is differentiated into cartilaginous and bony, right? So here is always be a demarcation, all right. So this is 1/3 and this is 2/3. So in 1/3, if there is granulation tissues are present, so we can see it on otoscopy, all right. So granulation tissue at junction of the cartilaginous and the bony external auditory canal, okay. So this can be seen. And also we know that it is like a malignant disease, right? So if it involves the like periosteum and the bones of the skull base, okay. So this is your ear. I'm very bad at drawing, so please forgive me. This is your eyebrows, and this is your hair and all. This is your nose, this is your mouth, okay. So it involves the periosteum and then the bone of the skull base, okay. So out of your here, this point here, this is your skull base, right? Here the brain is sitting here, a huge brain, right, that you are not going to use anyway. Sorry for the joke, okay. So it can spread, all right, from the periosteum into the bone. So what happens? So this brain has cranial nerves, right? Of course. So it can affect the cranial nerves. So what kind of cranial nerves can be affected? That is facial nerve, 9, 10, 11. So 7, 9, 10, 11 cranial nerve symptoms can be seen. That is the palsy can happen, right? And it is seen more on the diabetic and the immunocompromised state, we have already discussed. And if we do the antibiotic sensitive testing, like we do the culture, we can see pseudomonas in ear swab, right? We can do that microbiological investigation. So here we can see purulent ear discharge with like blood stained mucus and all mucoid, it can be seen. So that happens. So how does this progresses malignant otitis externa? So malignant otitis externa in the external auditory canal, it spreads out via the fissure of Santorini. Okay, what is fissure of Santorini? It is a deficiency. It is a deficiency in the cartilaginous part of the external auditory canal. So out of that fissure, the infection can spread from mastoid to the external canal, and from the parotid gland to the like in the auditory canal, or vice versa. Okay, so here the infection has been spread out from the fissure of Santorini. Okay, and to it causes cellulitis, and then chondritis, and then periostitis. Okay, skin, soft tissue, and then periosteum, and then to the osteitis, means bone, and then osteomyelitis, means bone marrow. So skin, so it progresses from skin to soft tissue, right? Wait, let me write that again. Skin, soft tissue, it is progressing, right? And then outer bone, and then bone, and then inner bone, right? So it progresses that way. Okay, like कुन बाटोबाट जान्छ भन्दाखेरि यसरी जान्छ भन्नु पर्यो के. So it involves the Hawaiian system of the compact bone first. Okay, so this is a very important MCQ question. Hawaiian system of the compact bone. So one, periostitis means outer bone covering, right? Periostitis develops, it spreads rapidly across the skull basis. So we can get the cranial nerve. So what were the cranial nerve that were affected? 7, 9, 10 and 11, right? So what are the investigations you are going to send for the malignant otitis externa? So CT scan to see the extent of the bony destruction. You can see how much bone is destroyed, and then you will like learn about 2-3 fancy names. All right, so please please stick with me. So technetium 99 scan and gallium 67 scan. Technetium, write that down 20 times. Okay, tectanium 99 and Galileo 67. Technetium 99, gallium 67. Technetium 99, gallium 67. Technetium 99, gallium 67. So these are the fancy, like with numbers and all. Others you have heard about it, I probably assume. So in technetium 99 scan, it detects the bone involvement before CT and remains positive even after 6 months of infection, right? Technetium. And then in gallium 67 scan, it is a sensitive monitor of infection. So out like कति infection भएको छ भन्ने थाहा पाउँछ के gallium 67 scan ले, right? And then and here the negative scan indicates termination of the treatment. That means the patient has healed, right? So if you want to do like more research about these two, please do. All right, you can find so many research articles about it, and literature on them. So yeah, and then now let's come to other CT, then SPECT. Okay, SPECT, SPECT. Okay, CT means computerized tomography, add SPECT means single photon emission computerized tomography. Yeah, that is seen here. SPECT, that is also can be sent. And then MRI, you have like heard it hundreds of time, MRI, CT scan, and then SPECT. So you can do that, which differentiates MRI, like differentiates from malignancy. All right. So now treatment. What is the treatment of malignant otitis externa? So the main treatment is control of predisposing factor. So you should control the predisposing factor, and that means diabetes mellitus. Diabetes mellitus, if the person is like has diabetes, then the target should be to attain the blood glucose level to normal. You have to like maintain the blood glucose nicely, and if the person is having like steroids for any other drug, or any other condition, then that should also be kept in mind. Risks versus advantage, that should always be weighed down. you know yeah, that should always be done, this or this. So that should be done for other condition. And then we have to treat the pseudomonas staph and the aspergillus and all. So IV antibiotic is required, right, for the acute phases. So the main drugs that are used are piperacillin, gentamicin, or ceftazidime, piperacillin, gentamicin, or ceftazidime. So go with whatever drug you find easy right now for exam purpose, right? So I'm going for gentamicin, but you can always choose, like you have to write all three, Okay, so piperacillin plus gentamicin plus ceftazidime. Okay, the piperacillin dose is 25 to 75 mg per kg, that is given per 6 hour, that is 4 times a day. And then gentamicin is 1 milligram per kg, that is given 8 hourly. And ceftazidime is 10 mg, 10 to 20 mg per kg, that is 8 hourly, right? And then oral antibiotic if the when erythrocytic sedimentation rate is normal. And then ciprofloxacin, all right. Ciprofloxacin is given for 2 to 6 months, that is 2 times ciprox for 2 months, right? And the dose is 500 to 750 mg, 500 cbd mg. And the main drugs used are piperacillin, this is given like 6 hourly, the dose is 25 to 75 mg per kg. And then zenta, I remember zentamicin, okay, sorry, mycin I thought, 1 mg per kg, and this is given 8 hourly. And then another is ceftazidime, that is 10 to 20, all right. 25 to 75, 10 to 20, 25 to 75, 10 to 20, 25 to 75, 10 to 20. Gentamicin is always 1. And then this is given 6 hourly, these two are given 8 hourly. Okay, and then oral antibiotic when the erythrocytic sedimentation rate is normal. Do you know why it is given only in the normal? Please, if you know the answer, comment down below, because I don't know. And then we give the ciprox for 2 months. The dose is normal dose is 500 to 750 mg per kg, for mg, 750 mg given 2 time BD. All right. And then debridement of the necrotic tissues, of course we have to debride the necrotic tissue. And modified radical mastectomy or radical mastectomy is not recommended, as it is said here. Okay, so now let's move on to, we have already discussed about the diffuse otitis externa and the malignant otitis externa. So let's move on to other condition, that is otomycosis. This is the disease of the external ear. So that's a fungus, right? So what happens is, any kind of fungus that grows is on hot and humid climate, right? And then it can be caused due to the long term use of the topical antibiotic effect. So this can be a viva question: what happens if a patient uses too much antibiotic for a long time? So you can always say it can be a risk factor for otomycosis or etiology. So what happens to the patient suffering from otomycosis? So it ear itch, all right, earache, and then watery plus foul smelling otorrhea, means discharge, that is watery and foul smelling at the same time. So what are the signs? So this is very important, okay, on your spotters and all, and even on your viva. So sign of otomycosis is black headed filamentous growth. Okay, black headed, wait a minute, I can draw that for you. So okay, this is, yeah, like this, black headed filamentous growth. Okay, filamentous growth means filament, black headed filamentous growth. So when you examine a patient with otomycosis, you can always see wet newspaper appearance, you can always say that. Okay, that is a spotter question. All right, wait a minute, let me fix the size of this. Yeah, so yeah, that happens. All right, so wet newspaper appearance or wet filter paper appearance, wet filter paper appearance. All right, so that is also a sign of uh, like uh, otomycosis. And okay, that there are many causative agents for this otomycosis. Okay, that is aspergillus niger, and then we can also see due to candida albicans and aspergillus fumigatus and aspergillus flavus. So 1, 2, 3, 4. Aspergillus niger, Candida albicans, Aspergillus fumigatus, and Aspergillus flavus. Okay, so for Aspergillus niger means black. Okay, so that means black-headed filamentous growth. Okay, and then Candida albicans, it's like very white colored fungus, right? So you can see white colonies, that is cotton wool or wet blotting paper appearance or wet filter appearance, like I have told, right? Cotton wool, it will be seen like a fluff of cotton ball, and in that is Candida albicans. And if it is fumigatus and flavus, don't get confused with fumigatus and flavus. All right, so Aspergillus fumigatus, okay, so that is blue. Okay, gatus blue or green, G for gatus, G for green or blue. Okay, green and blue, BG. Okay, so remember that aspergillus fumigatus means green or blue, and then in aspergillus flavus you will see yellow colonies. So if you are examining a person with automycosis, you are more likely to see four colors. All right, one's white, one's black, another is blue or green, and another is yellow, and it was all yellow. Okay, so white is caused due to candida albicans, black is caused due to aspergillus niger, blue or green means aspergillus fumigatus, and then aspergillus flavus causes yellow. Okay, okay, flavus, flavus. Okay, so if you add a line on v, it will give you yellow. Okay, so that's a trick to remember. If you don't know, if you know it, then good for you. So see here, this is a white color, right? This is a white color, so you already know candida albicans, and you can see the cotton ball, cotton ball, yeah. And filamentous black-headed growth, like I drew the picture. Let me draw it once again. Filamentous black-headed, this is aspergillus niger. What else it could be, right? So it's so simple. And then, okay, so we have like flavors, like y flavors. Okay, aspergillus flavus means yellow. You can already see it's not white, it's not black, it's not green or blue, so it is yellow. So this is caused by the flavus. V means yellow. Okay, and then fumigatus, G means green. All right, so aspergillus fumigatus, or bluish green, you can find the spectrum of the color as well. So what is the treatment? The main treatment of the fungal is removal of fungal debris from the external auditory canal, and clotrimazole, this is the very important drug, right? And lignocaine ear drops for the earache. Okay, clotrimazole and lignocaine ear drops, 3 drops, 3 drops, 3 times a day for 3 weeks. Okay, 3 drops 3 times a day for 3 weeks. Clotrima, clotrima, clotrima plus lignocaine ear drops. Okay, you have to put the ear drops on your ear. So that's about it for the complete eradication of the fungus. Also, don't forget to removal of the fungal debris. And then 2% of salicylic acid in alcohol eardrops acts as a keratolytic to remove superficial epidermis along with fungal mycelia. Okay, जुन fungus को mycelium हुन्छ. Okay, the fungus mycelium, that should also be removed. Okay, and then for it, like you have to remove the superficial epidermis so that the remnants of the fungus won't be long there. All right, so it can always cause remission, right? So you can also use 2% of salicylic acid in alcohol airdrops, so it will lysis of the keratin. All right, keratin means like our skin, dead skin. So keratolytic to remove the superficial epidermis along with the fungal mycelia. So it's very important, 2% of salicylic acid. So one of the what are the treatment for fungal ear? Number one is removal, debridement, यो fungal clear गर्नु पर्यो. Second is clotrima plus ligno for 3 drops 3 times for 3 weeks for complete eradication. And then we can always use salicylic acid. Salicylic acid is 2%, don't forget the concentration. Salicylic acid plus alcohol, that will, what does it cause? It causes keratolysis of the epidermis and then the removal of the fungal mycelia. And then we can also do cotrimazole, antibiotic, steroid, lignocaine eardrops for associated bacterial infection. You always use that combination, right? So now let's move on to herpes zoster ophthalmicus. Okay, so this is a viral condition. So herpes zoster oticus, this is ENT, so we are reading about oticus. On ophthalmology we will read about ophthalmicus and all. So herpes zoster oticus is caused by, it's like obvious, like come on, varicella zoster virus, right? So chickenpox is primary, and the herpes zoster is its reactivation. It's also known as Shigels, Shigels, right? So it occurs primarily, and then herpes zoster is its reactivation. So what is the characteristic? Like vesicle form on a red base, there's a red base on the on the skin and external ear and the face. So here is all in the ear and the face. This is herpetic zoster, herpes zoster oticus, right? Ear and the face, even on the lips. Herpes zoster oticus, say it with me, herpes zoster oticus. So As vesicle burst, amber fluid drains out with crusting. Okay, so this is amber colored fluid, it will drain out from the vesicle if it bursts with crusting. Okay, there is crusting also. So this is herpes zoster orticus. You can always like prescribe antiviral, and then as it is a viral disease, like you have to wait for some time and then like do the conservative treatment, right? Okay, now let's go back to now let's go forward to Ramsay Hunt syndrome. Okay, Ramsay Hunt syndrome. So it is named after of like a person named Ramsay James Ramsay Hunt. So what happens here? It is a herpetic infection of geniculate ganglion of the cranial nerve 7. Okay, so cranial nerve 7 means it's a facial nerve, right? Facial nerve. So it like the infection in the infection by herpes in the geniculate ganglion, GG. Okay, geniculate ganglion infection of the cranial nerve 7, that condition is called Ramsay Hunt syndrome. Okay, and it is the commonest cause for facial palsy after Bell's. So number one cause for facial nerve palsy is Bell's palsy, and the another is Ramsay Hunt syndrome, right? So clinical features, the clinical features involve herpes zoster eruptions in the external ear plus facial palsy, and plus or minus like sensory neural deafness can occur or not occur, and also vertigo, plus or minus vertigo, right? So antiviral, as I talked about earlier, so that is acyclovir, that can be given 800 mg intravenous or per oral 5 times a day for 1 to 3 weeks. For three weeks we have to eat 5 tablets in a day, or if you are trying to like give it in IV, then like 800 mg works, IV one time. And then prednisone, it's a steroid, right? So 1 mg per kg per day per oral for 1 to 3 weeks. And then amitriptyline, it is used for post herpetic neuralgia. You have already studied this in CNS as well. If you haven't studied about anesthesia in a major, then CNS in the anesthesia topic of the pharmacology, you have like read this. Amitriptyline is used for post herpetic neuralgia, so its dose is 25 mg 3 times a day. So this we can see Ramsay Hunt syndrome, right, in the ear and in the mouth and the face and all that. So in the facial nerve palsy can be seen along with the like sensory neural hearing loss, and vertigo, plus or minus vertigo. So let's go to the keratosis obturans, right? What is keratosis obturans? So it is also known as canal wall cholesteatoma. So it is a collection of white mass of desquamated epithelial cells in deep external auditory canal. Okay, in the deep EAC there is collection of white squamous like mass of desquamated epithelial cell. Okay, desquamated epithelial cell, desquamated epithelial cell, it's a white mass. Okay, it's a white mass, this is red but it is actually white. Okay, so it occurs and it is caused by the like okay, so what happens is in your ear all these the epithelial they are, so they they come out, they die, eventually they die, right? So they migrate as well, so they have to migrate, otherwise like it will cause collection and then conductive hearing loss, right? So this is external organ. So normally all the debris, they normally like migrate towards the outer canal, and like we get ear waxes, right? So what is that? That is normally desquamated epithelials, right? So that is caused due to the epithelial migration. But if there is a failure of epithelial migration in the external auditory canal due to the obstruction by a wax or exostosis, so any kind of wax is present here or any kind of bony growth is here, then epithelial migration cannot take place. Okay, so it will cause collection of white desquamated, okay, epithelial cells mass in the deep auditory external auditory canal, so it will go inside, right? So what comes next? Okay, so the pressure effect of the mass that will cause the bone absorption plus widening of the external auditory canal. So this is your external auditory canal. So here is an wax or exostosis, epithelial migration can't take place, so it will go deep into the epithelial deep into the external auditory canal, and then that will lead to pressure effect. That means here is a bone, right? Here is a bone, so it will cause pressure effect and then it will cause widening. Okay, so your ear canal becomes like this. First it was like this, so the migration occurred, desquamated over white ball occurred, so it is pushing down, so there is a widening of the external auditory canal. All right, so it is also like associated with bronchiectasis and sinusitis. Okay, this is like there are some syndromes associated with bronchiectasis and sinusitis in which there is no migration, the cilia dysfunction, so cilia can't function properly, so it can't beat, and then it will cause all these symptoms. So keratosis obturans is also like associated with bronchiectasis and sinusitis. So symptoms, what are the symptoms of keratosis obturans? They are earache, of course, hearing loss, and then otorrhea. So what is the sign? Pearly white mass of the keratin arranged in concentric layer. What is concentric? Means the center of this circle is the same. So if suppose this is a keratotic obturans, this is a pearly white mass of keratin. This is all desquamated epithelial tissues, right? So they are arranged in concentric layers, like, right, like onion, like an onion. So concentric center, and then with EAC widening, of course, due to deep EAC, it goes down due to the wax or the like exostosis, and then it will cause ulceration. Of course, it will cause ulceration, and then here granulation forms. Okay, so this is very important. Keratosis obturans. So treatment is done by the removal, like you have to remove the white mass of keratin, right? Instrumentation under the local or general anesthesia, because it is painful, and then it is the patient is advised to follow up regularly for to rule out the reoccurrence, right? So yeah, you can see here poorly white, desquamated mass. Look, due to exostosis, maybe this is an exostosis or airwax. So all this is happening. Yeah, so this is taken out, this is taken out from the air, and then you can see that. Okay, now let's move on to bullous myringitis. So bullous myringitis, it is also known as otitis externa hemorrhagica. Otitis externa hemorrhagica. Okay, it is characterized by the rapid onset, severe pain, and blister formation on the tympanic membrane. Okay, so let us see an image. Okay, yeah, so this, bullous myringitis, it's very painful, right? Look at this. So here what happens is otitis externa hemorrhagica. Okay, blood. So rapid onset, it happens very rapidly, and pain is severe, and then we can see the blister formation. Okay, so three features. Okay, rapid, okay, painful, and then blister on tympanic membrane. So these are the three features of bullous myringitis. Okay, so etiology, it is a character. Okay, characteristics. Okay, so etiology, what causes this bullous myringitis? We don't know. It can be virus or mycoplasma, we don't know, but it is considered to be virus mostly. So in bulle, it is filled with serous or hemorrhagic fluid. Okay, and then here we can treat for that, we can do treatment is analgesia, and then topical antibiotic, and then corticosteroid airdrop. So if there is rupturing of blister occurs, then EAC packing or irrigation should be avoided. We have to let it be. Okay, so after bullous myringitis, we come to the granular myringitis. Okay, so we already know about the bullous myringitis, but there was blister formation on the tympanic membrane. But in here granulomatous, granular surface can be seen in the tympanic membrane, right? Granulations. So that is granular myringitis. Inflammation of the intact pars tensa with persistent granulation tissue on its lateral surface. Okay, it's a pars tensa, pars tensa मा चाहिँ इन्फ्लामेसन हुन्छ, and then there is a inflammation on the, and then there is a granulation tissue on its lateral surface, there will be granulation tissues. So what are the clinical features? It will cause mild otalgia and then air discharge, right? So what is etiology? It is due to either local trauma or infection that denudes epithelial layer of the tympanic membrane. Okay, so any kind of local trauma or the infection that can causes denudes the epithelial layer of the tympanic membrane, right? So what can we do? The treatment for granular myringitis is cauterization with silver nitrate sticks and topical antibiotic plus corticosteroid. Okay, antibiotic plus corticosteroid, plus silver nitrate cauterization, right? So this is bullous material. Okay, now most common, okay, air wax. Okay, so this is very important. Air wax or kani guzi or cerumen. Okay, so what is wax? So wax is a like combination of secretions of the pilosebaceous or ceruminous, or that is also modified apocrine glands. Okay, pilosebaceous and then modified apocrine gland, and plus desquamated epithelial debris plus keratin, all right, or dirt, that makes a air wax. So recipe for air wax is secretions of glands, that is pilosebaceous and ceruminous, which is a modified apocrine gland, plus desquamated epithelium debris, okay, that's keratin only, and then dirt and all, you know, that all causes earwax. That's the recipe for earwax. So sebaceous glands, they secrete fatty acid secretion, and ceruminous gland secretes watery secretions. Okay, so we can always like get the, you know, sticky and the, you know, gooey type of earwax. So earwax is expelled laterally by the movement of the jaw, because like when you move the jaw, the wax is expelled laterally towards the outer world, right? So we can see here modified apocrine gland is here, and then here is sebaceous gland. All right, sebaceous fatty, ceruminous means watery. So look at here, so it's very dirty. Okay, very dirty earwax. So cause of retention, why does earwax like it retains, मतलब त्यही किन अड्किन्छ त, why does it retain? So excessive secretion from the glands. So if the glands are like producing like, you know, fat and watery discharge like crazy, then it will of course retain you know, like it can't discharge so fast, right? So excessive secretion from the gland, and sometimes it is due to the narrow or tortuous air canal, right? So if the ear canal is small, very small and tortuous, right, so many bumps and lumps, so it can't drain, right? So it will cause retention and then cause conductive hearing loss, right? So that's it. And then stiff ear. Okay, in the outer one third, there are gonna be like hairs, right? So if there are so many hairs, then of course the wax will like retain. And then obstruction in the ear canal, that is exostosis, means any kind of like bony growth happens in the ear canal. So of course, like the same like stiff ear, you know, any kind of obstruction like that will cause. And then in the dry and dusty climate, you know, that will also cause retention. So this is also occurring. So now types, it is either moist, you know, honey color, that is wet, and dry is gray and brittle. Okay, comment down what kind of earwax you get. Okay, so what is the function of earwax? So function is actually it is antibacterial action, and then entrapment of the foreign body. Suppose like small fly decides to go in your ear and then play some drum on your tympanic membrane. So like the wax is like, wait a minute, you can't go inside because I'll stick your like hands and feet and your wings. So yeah, entrapment of the foreign body, right? And then lubrication of the action auditory canal, lubrication, antibacterial, and then entrapment of the foreign body. So what are the features of the retention of the earwax? Retention of earwax को features कस्तो हुन्छ कान चिलाउँछ, ear witch, itch, deafness, that is conductive hearing loss, tinnitus, giddiness, reflex cough. Okay, so this is new to me, I didn't knew this. Okay, reflex cough can also occur due to the stimulation of the auricular branch of the vagus. Auricular branch of vagus, auricular branch of vagus stimulation causes reflex cough in retention of the earwax. And then its complication is granuloma. Okay, it can cause wax granuloma, pressure granuloma, like that. So treatment, how to remove a earwax? The answer is simple, you just remove it, right? So using a Jobson horn probe, you can like google it right now, or then I will also make another instrumentation video, but I think you know what a Jobson horn probe is. So you have to remove it by instrument, you know, or use that earbud tips and all. And syringing, but you are in OPD, then they won't use earbuds. Okay, they will use Jobson horn probe. And then syringing. Okay, so what is syringing? We use a sterile saline at 37 degrees Celsius. Why at 37 degrees Celsius? Do you know? If you know the answer, please again comment down below why they use 37 degrees Celsius or lukewarm water. And then first a space is created between wax and canal wall. Okay, and then tip of the oral syringe, okay, Simpson's oral syringe, we will see the figure, is directed toward the posterior superior wall of the ear canal. This is very important MCQ. Where to die Simpson's oral syringe is like this, something like this, it's a big syringe. So when you're putting it something like this, for syringing in your ear, somebody's ear, where have to, like, if you will put this directly, then it can rupture the tympanic membrane, right? So you have to like always like direct towards the posterior superior, sorry, posteriorly and superiorly canal of the air canal. Okay, so that will not cause any kind of damage to the tympanic membrane. So syringing is done, instrumental removal, syringing, and then suction clearance. So there are new machines, that can suck out the earwax, so that is also useful. And then if the earwax is very hard, then we can use the wax softener or H2O2 or ceruminolitic eardrops. Okay, that is paradichlorobenzene eardrops, so we can do syringing easily. So yeah, here look, the patient has an earwax here. So this is Simpson's oral syringe. Yeah, this is the Simpson's oral ear syringe. So large volume of 37 degrees Celsius water, lukewarm, large volume of 37 degrees Celsius lukewarm water is kept here. And then the syringe is like directed posterior superiorly, and then it is pushed, pushed here, and then the water will fill out, and then by like pushing action, the earwax will come out and you are collected in kidney tray. So that's how you treat earwax. And also you have, I think you have seen this in like TikToks and internet also. So they use this wax candle for treatment also, but the scientific community is not so sure about it. I don't know, but yeah, we don't do this, this is like another branch of healing and all. So we are like medical students, right? So we will only stick to instrument removal by Jobson Hunt probe, syringing and suction, and then if the wax is hard, we can use ceruminolitic eardrops as well. So now the very important part, all right, so this is a foreign body ear. This can be used in your daily life as well. So foreign body in your ear. Okay, this can be like classified, all right. So कानको पुवालमा त जे नि जान सक्छ नि त, either it is living or non living, सानो तिनो बच्चाहरूले हालिरहेको हुन्छ या किराहरू छिरिरहेको हुन्छ. So in the foreign body ear, like we can classify what type of foreign body it is. It is either in non living or living, right? So in the non-living, again, it can be again classified into inorganic and organic, right? So in living you can't classify the same, because living means organic directly, so that would be stupid. So okay, in organic, non-living and living. Okay, so in non-living, inorganic, that may be either paper piece or sponge or steel pencil, slate pencil or chalk piece, plastic beads, metallic, anything, the kids, they whatever they like use it, right? That is made out of plastic, and plastic or any kind of like small items, toys, even toys, right? They are also inorganic, non-living foreign body here. So that is non-living inorganic foreign body. And in the organic, they use like grain seeds and vegetable sheets, maize, and then they put so many things, right? Organic. And also in inorganic, you can always put like button batteries, right? Button battery, small batteries that come, like you can put it in your watch and all. So yeah, that also occurs. And then living we can find the flying and crawling insects and maggots, right? So that's it. Abba, now let's talk about, look here, what are these, some kind of like bean it is, I guess. This is some kind of cotton bud, I guess. I don't know what is this. This is like silica, I don't know, like foreign bodies. This is, yeah, you have to take the history from the patient also. So simple and problematic, all right. So it is I again like distributed into simple and problematic. So this is simple means it remains there, does not cause any kind of like any kind of pathology, and it does not worsen the symptom, right? Simple. But in the problematic foreign body, look, this is a organic, like I guess this is a pea, right? So it can like rot, it can get rotten there, and then again cause bacterial super infection and all. And this is an insect, either a mosquito, right? So it can scratch the tympanic membrane, it can bite the tympanic membrane, so it can cause problematic foreign bodies, right? And this is a like foreign body or battery, right? So battery is very 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 dangerous, and I don't know what is this. I think this is some kind of like metal, like mercury or something, I don't know. Okay, so these are very problematic, right? Yeah, yeah, this is a P. Okay, so organic are very harmful. So how to remove it? This is an emergency condition actually. When somebody comes on the ER, you have to like take the foreign body very fast, all right. And button battery is the very dangerous one. Mm, and like it can cause coagulation, sorry, necrosis and all. And the insects can also cause biting and all. So methods of removal of foreign body from the ear. So for soft and irregular foreign body, we can always use crocodile forceps, right? So soft, smooth and non-hygroscopic foreign bodies, like it cannot be like hygroscopically captured, so we have to do syringing. And then insect, so first we have to, if there is insects, we have to like suffocate the insect by like oil installation, right? So some or glycerin or something like that, small drops, 2 3 drops of the oil can suffocate the insect so that it won't cause more harm. And then by syringing we can like take it out. And then hard foreign body, it can be removed with a foreign body hook or ring curate that comes with the Jobson horn probe. So hygroscopic, that is vegetable seed, that is ring curate. And then it, we should avoid, this is very important, okay, we should avoid syringing, because in the hygroscopic the foreign body swells up and becomes impacted, it will more impact the canal. And then impacted foreign body, impacted foreign body, it will cause failure to remove failure impacted foreign failure to remove the foreign body early. It can be removed by a post oral approach with microscope under general anesthesia. So if there is any kind of impaction, right, if there is a foreign body that is impacted, it can't get out, like you can't get in, so what you gonna do? So you're gonna go from behind, okay, so you're gonna make an incision behind in the post auricular groove, and then get access to a canal, and then you can like take out the impacted foreign body with microscope and under general anesthesia. So that's about it. And then maggots, they are very nasty insects, they can like crawl in your ear and can cause like very much discomfort to you. So you have to put chloroform water and then forceps removal, chloroform to suffocate them. And then button battery very dangerous, it should be like very emergency, like very emergency emergency condition, right? So you can't do syringing, right? And then forceps removal should be done. So that's about it. So impaction, talking about impaction, so what is exostosis and osteoma, right? So osteoma means, let's make sense out of this word, right? Osteo means bone, oma means like growth, cancerous type, but oma, okay, so it is a bony growth but that is cancerous, right? So the cause of exostosis is due to like more due to like cold water, right? And then osteoma is like growth of the bone. So we are talking about that impacted impaction. So we are reading about multiple exostosis and osteoma. So the let's find out the differences between, right? So exostosis is more common, osteoma is less common, all right? So exostosis is caused by the cold water surfing, and osteoma maybe due to tumor, so that is unknown. And then exostosis, cold water, right? Cold water surfing, so it is also known as surface air, right? So it can occur, like it's not that if someone is surfing, then only like cold water goes into one ear, no, it goes to both. So right, so that's bilateral condition, and osteoma is generally unilateral. And then it is like a shape of the osteoma is exostosis is sessile, not pedunculated, sessile and hemispherical, right? Sphere, hemisphere, right? Hemispherical and sessile, whereas in the osteoma it is pedunculated and round. So what is the location of exostosis in the external auditory canal? So it's deep, okay, it's a deep structure. So this is an EAC, then it can occur here deeply, all right? Exostosis deep, it occurs deeply, whereas osteoma is more on the, superficially it is located in the AC canal. And then there are multiple osteomas, all right, but exostosis, there are multiples, but in the osteoma there are single, right? So that is the difference between the exostosis and osteoma. So with this was the last slide for the session, the diseases of the external ear. I will like link the video to the part 1 as well. Please check it out, and then please check out my playlist as well. I have made a series of ENT ophthalmology, and I'm planning to conduct more if I get time. I don't know, let's see about that. But yeah, please, if you find it helpful or in any kind of way, then please consider subscribing, and then like share it with your friends as well. And then if there is like anything I can do to improve in the videos, please let me know in the comment section. Like yeah, please share or like or anything, all over all that part. But still, thank you for standing by, thank you for hanging by. We will come back soon, and yeah, thanks.